give the ball to Jonathan. Thank you.
Hi, good evening. Thank you for the introduction. Welcome to the blood chemistry analysis from Functional DX, identifying hidden health trends. And we'll start off by a declaration of interest, which is to say that I am a director of FDX, and therefore I think it only appropriate that I should declare that I have a financial interest in this particular project. Having said that, the objectives of this webinar tonight are to demonstrate that blood chemistry is essential for efficient and accurate practice, that FDX, or functional diagnostics, is the most sophisticated blood chemistry analysis program anywhere, how you can use this to enhance your practice value and business, increase volume and scope of work, get faster and better results, and the simple fact is that FDX is fantastic value. In fact, I'll go as far as to say I've never come across anything that's better value. So there's been a brief introduction about me, but let me show you the functional diagnostics team. So this was evolved by Dr. Weatherby, who is a graduate of the National College of Natural Medicine. He has 25 years of clinical expertise in functional medicine and diagnostic medicine. He's a renowned international lecturer, teacher, an author of 6 or 7 books. He's the world leading expert, in my opinion, in functional blood chemistry analysis. His best-selling book, Blood Chemistry and CBC Analysis, Clinical Laboratory Testing from a Functional Perspective, is used as a teaching tool across the world in medical schools, institutes of higher learning, in America, Canada, Australia, New Zealand, and even in the UK. And it's really the go-to blood chemistry reference manual for thousands of physicians and healthcare practitioners worldwide. And this is what's all been distilled into the functional blood chemistry analysis software program. And this is the only software program based exclusively on his work in this field. And it's frankly the gold standard assessment tool for thousands of us practitioners worldwide. And or at least 20,000 blood tests now have been run through the program. In 2006, when I first started my master's in Worcester, one of my colleagues came into class one day with a book called Signs and Symptoms from a Functional Perspective, written by Dickin. And I found it fascinating and great because, here's a way of assessing clinical signs and symptoms and then assessing it to dysfunction and further then assessing it to nutritional need. And this was really exciting for me, something I knew very little about. And so I avidly got a copy of that. And then I also got a copy of the book referred to, the CBC analysis book. And of course, I knew nothing of blood chemistry. I mean, I've seen blood tests. I don't know what they mean. I wasn't a doctor. High sodium usually means this. Okay, we knew that. High cholesterol, high glucose. I mean, the standard things that we know. But all those other mysterious names on there, like alkaline phosphatase or ALT or GGT, or none of them meant anything to me. And so I started trying to make sense of all of this. And there was the book. There were the notes in the book. And then forms to write down what was on there. And so I avidly began collecting blood tests from anyone and everyone who went to doctors. So, well, let me have a look at your tests. I'd like to try and analyze them. And that's what I did. And I started to become reasonably adept at just running through the test, but it took me forever. I mean, really, I could spend 2 hours on assessing what I thought was assessing. And I'd end up with a piece of paper that had arrows all over it and lines all over it and whatever. And then as I got to know Dickin quite well, and I became a beta tester for the software, I suddenly found that 2 hours of work went out the window. And here was something that could put a report together that was utterly brilliant in terms of making my life easy, presenting something to clients that looked so professional and fantastic. And I just realized that this was something that had to be brought to the UK and to Europe. And that's where I am today. I also have another director as part of the company, Justin Price. He is the logistics, sales, marketing, and a driving force in the company. He's a commercial man, 28 years in various businesses, 15 years particularly in the health and microbiological field, and since 2011 very actively involved in the functional medicine field, culminating in becoming the CEO of Regeneris Laboratories, which is probably now the leading provider of functional medicine tests in the UK. Of course, myself, my background, I am the founder director of Functional DX. I've got 25 years of clinical therapy experience, and I am a registered nutritional therapist, a member of BANT, registered with the CNHC. I worked as a BANT director and BANT treasurer for a number of years. As a clinic director, I work at the Centre for Applied Nutritional Health, and I specialise interest in complex and chronic conditions, including Lyme, ME, cancer, multiple chemical and environmental sensitivities. I'm also a registered nutrigenetic counsellor, and I'm a nutritional advisor to the Multiple Chemical Sensitivity Aware charity. I also teach occasionally, mentor quite a number of students and practitioners, and I'm a consultant as well. And frankly, every single patient that comes in to see me, or client, whatever you'd like to call them, I insist on two things nowadays. One is that they produce a online questionnaire filled in, which is all based on Dick and Weatherby's original Signs and Symptoms book, and they come in with some blood tests, because everybody has blood and everybody understands blood. And so if we move on to this subject of blood testing and patients and healthcare providers, we can see that, and we know that patients understand, and they're educated, we're all educated, that blood testing is the norm. You go along, you stick out your arm, somebody comes in, they suck out the blood, it goes away. Mysteriously, the results appear on a piece of paper, and doctors tell you, don't worry, everything's fine, you're fantastically well, you've got nothing to worry about, whether you feel it or not. Blood testing is the most commonly ordered laboratory test, and most patients will have had a blood test done in the past, so they understand and they're educated, as I've just said, and they will have access to obtaining one either through their mainstream healthcare provider, i.e. their GP or whoever else they choose, or their private healthcare provider or therapist. Patients can also get access to their past results if needed for analysis. Again, you can go to your GP or your doctor and you can ask for copies of your past blood tests. And if patients don't have one, I say, well, go along and get me your past copy. Let me see what was happening at least a while ago. Are there any clues? Because I like to start off working with clues. And I know that patients will be prepared to have a test performed as they understand that blood contains answers to their health. In fact, an important point to make here is that often the first signs of illness may be present in biomarkers in your blood long before it manifests as a clinical dysfunction. And we know that in the field of healthcare, many doctors and healthcare professionals do not recognize functional tests like organic acid testing, stool analysis, heavy metal toxicity testing. But blood is a universally accepted medium for investigation and health. And so it's a fantastic way for us as therapists to use to work with doctors, to work with our patients. An estimated 60 to 70% of all decisions regarding a patient's diagnosis, treatment, hospital admission, discharge are based on laboratory test results, according to the Mayo Clinic from the Mayo Clinic of Health Sciences. The use of clinical laboratory test results in diagnostic decision making is an integral part of clinical medicine, according to Wyans in the clinical laboratory test reports. And in this report, he talks about algorithms. Well, functional diagnostics, or FDX, uses algorithms to establish health trends. And he goes on to say that medical algorithms are particularly useful in establishing diagnosis because they're logical, they're sequential. They can be automated, which FDX does, because it uses a computer to achieve rapid turnaround time of results for tests. Maximize a clinician's efficiency, because you now can be really focusing on what's in front of you. You can minimize the ordering of unnecessary tests. So if you can find answers in the blood test, you won't need to go off and do organic acid tests. Clients have got limited amounts of money. Can be used by other ancillary medical personnel. These can be easily updated for improved strategies for diagnostic decision making as new and better tests become available and are incorporated into software programs that are relatively inexpensive to purchase and use. Well, I should say that functional diagnostics, FDX, is not diagnostic. Diagnosis is only something that can be done by a medical healthcare professional, a registered medical healthcare professional, which I and we are not. So what we say, it is a health trend reporting tool. What we see in this tool is a trend away or to a set of optimal health parameters. And because it was so good and so fantastic, I brought it over exclusively for the UK and Europe. One, because getting in-depth reporting at a low cost was almost impossible. Two, finding blood chemistry testing that was wide enough in scope, i.e. biomarkers that were more than the typical doctor's NHS test, meant that they were very expensive, and I wanted it affordable. I want to bring prices down, that when I'm working with patients, and I say to them, I'd like you to carry out this test and this is what we're going to get, and they say, oh, I can afford that, fantastic, it makes my life easier and gives them better results. And so this trend analysis reporting was devised for both practitioner and patient, and more importantly, to make sense out of what you got from the GP and other laboratories, which is linear methods of reporting, just one long line of analytes. And the beauty of this is practitioners do not have to be experts in blood chemistry because the program explains everything to them. So let's see the following examples of linear reporting. Example 1, patient missed CH. This is linear reporting. It's a typical NHS lab report. It's a simple one-page report. And prima facie, when you look at this coming up in the next slide, there's little to comment on, yet imagine that you had a two-page report like this. And sometimes you get these reports from the doctor's surgery, and they go across 2 pages, because it's how they print them out. I mean, how on earth you look at that, and then how do you compare past tests with each other when it's just one long printout? It's nigh on impossible. There are 27 biomarkers done on this test. It's in black and white. There's no indication of high or low values. It's hard to read, and there's no report on the combinations and suggested dysfunctional trends that the FDX reports do. And this is the report. And as you can see on this report, it's just a list. Now in this list, as you scroll down from the top, you come to mean corpuscular hemoglobin. It's in dark black, or in bold, I should say, as MCH. That is elevated clinically. And further down, serum magnesium levels are elevated as well. There was nothing on there to suggest the doctor will do anything because there's only 2 markers out of range here, and that may be the norm. I'm going to show you a little later. There's an awful lot more on there when you deviate from away from an optimal range. And in fact, the magnesium level is also indicative of something I've suggested for a long time with this particular person, that they were subclinically hypothyroid. The next example is Mr. G, and on the 3 pages, because he had a very expensive and long test done, 60 biomarkers, again linear reporting. In this one, because ranges out of items out of range that are elevated or depressed are marked in red, and the ranges reported are clinical, not optimal. And you're going to see with large amounts of data, associations become complex, and you have to have algorithms. You have to have ways of arranging the data together. So a complete list from hematology running all the way down through biochemistry. The first column is the result. The measurements are next, and then the ranges that are used by the laboratory are the last column on the right. And down at the bottom you can see that creatinine is elevated and it's marked in red. Moving on from there, we can see on this page that the items in red are alkaline phosphatase, and then there's a fasting cholesterol of 6.6 also elevated as well. The fact that I can see the alkaline phosphatase is so depressed there, I mean, it's clinically depressed, makes me very concerned for this person's zinc status just by looking at that by eye. And then we come on to the last page, which is the blood glucose triglycerides. The hemoglobin A1C, or HbA1c, is the glycosylated hemoglobin, which is a measure of blood glucose levels over a period of time, usually something in the region of 3 months, something like 100 days. And you can see at the bottom, this lab does a fasting insulin test, and then takes the results and runs them through something called the HOMA calculator to get the insulin resistance index, which you can see is 2.3 times above its base of 1, which suggests this person has a blood sugar mismanagement issue. It doesn't have to be that complicated, because if I go back, I mean, if you take all that data across all those pages, how do you make all the associations? It's complicated, but it doesn't have to be that complicated because it's simple. I guess this is a bit of a simple plug, really, but if you're qualified, because FTX at the moment is only for registered therapists, i.e. people who have qualified, then register. Choose from the panels, pay the fee, get your patients to draw their blood, wait for the results, usually within 7 days, and the results are going to come in the form of a very detailed, comprehensive PDF report, which is about 40 to 60 pages in length. And you get 2 reports, one for you, and if you want to supply, one for your patients. Moreover, if you or your patients have your own results, we also have an interpretation service, so we'll take those and we'll plug them into the program and we'll produce a report anyway. So why FDX? What's all the fuss? Well, first of all, we're identifying hidden health trends. FDX uses trend analysis to establish clients' otherwise hidden health trends. You can't see the health trends in there unless you start getting a program to start reporting them. And there's a deviation away from an optimum health norm, and we do not diagnose, we just look for the health trends. The optimum markers that we talk about are ranges that were once considered to be healthy. These are ranges that have been used by the old timers. In other words, the old school doctors who knew what they were doing and what was healthy, and through observational studies. They're much narrower in range, and because they were used in a time when the population was not as sick as it is today, are instrumental in identifying when trends start and how far down the slope away from optimum your client has gone. Simply put, the sicker a population becomes, the larger the standard deviation extends out from what was a healthy range, which may or not have been that healthy then. In other words, you create a bell curve, and it can become smaller or it can become larger to encompass the population that you consider to be healthy. So where people were once perfectly healthy, they may be missed. Where people were sick, they suddenly become healthy. So we have causative problems because if you make the association between cholesterol and obesity, and say a higher cholesterol causes obesity, then you start to create a higher level. Whereas if you were dealing with glucose or blood sugar and triglycerides with obesity as causative factors, then a higher level of cholesterol may not be unhealthy. But now we're told it's unhealthy. And I thought I would just mention the work of Dr. Malcolm Kendrick, who does a fantastic blog, and John Briffaut does great books. And you should have a look at their work on this particular area and read what they've got to say about high cholesterol levels. Are they really unhealthy or not, and whether it is stress and sugar that is at the root cause. We as nutritional therapists know what everyone else should know in time. They're coming around to our way of thinking. So a standard deviation or bell curve is a curve where you can see right in the middle of the box at the top. I'm sorry, I can't get the pointer to work on this, so I do apologize. You'll see right in the middle the letter mu. This is the mean, and then to either side of it you've got mu minus delta or mu plus delta, which is moving down one or up one standard deviation. So the population study all fits in virtually into this bell curve, and then 68% of them will fall into the 1 standard deviation, then 95, that typical statistical 95%, falls into the 2 standard deviations, and then your 99.7% of the data is incorporated into 3 standard deviations. And I don't know what happened to the remaining 0.3%, but they kind of get lost in the whole scheme of things. I'm on their side. I want to get them healthy. Not all values are bell curves. For example, looking at GGT or gamma glutamyl transferase, the data is not a Gaussian distributed range, and so you get this odd-shaped curve. In this case, our optimum range is between 10 and 30 units per litre against a sort of clinical range of somewhere between 5 and 50. So let me explain this as follows in a slightly more light-hearted and humorous way. Allow me to introduce you to the norms from the mountain of Norm. We have Norman on the left and Norma on the right, and these are healthy medical norms. In other words, they live in that lovely area which is in 2 standard deviation points and that clinical range, and they're considered healthy. It's fine. So, but Norm worked hard, and so he worried and he was stressed, and eventually became tired and exhausted, and eventually started filling out and gained weight. This is something we see a lot as nutritional therapists. He went to his GP and he had routine blood tests, and they showed normal clinical results because they all fell into the normal clinical ranges, in that 2 standard deviation point, and was told his cholesterol and glucose levels were still normal. Everything is as it should be, Mr. Norm, he was told, but it wasn't, and eventually he found himself down from the mountain on the plains of Farmer, looking up at his hospital, looking up at his mountain home through his hospital window. And for Norm, who loved his home, there was only one thing to do. So he missed it and tried to escape back. But once you're down on the plains of Farmer, once you've moved outside that clinical area and you're into farmer territory, climbing back up the mountain to the Norm household for anyone is no easy task. That's why nutritional therapists are so essential. The moral of this tale: don't let the norms of this world slide down the slippery slope. Catch them early before they slide down to the plains of Farmer. And the way you can do that is to start using tools like FTX. Just to illustrate a bit more about the standard deviation points, to give you an idea about how ranges change over time. In 2015, glucose level ranges are between 65 and 95 milligrams per deciliter. Back in 1960-62 in the USA, Department of Health blood glucose survey, they reported the average male, that would be the mean, at 115.7 micrograms per deciliter, and the females at 126.4. That's a heck of a shift over 50 years. So these are how ranges change. Yet our optimum range is between 75 and 86. So in other words, you don't want too low a range and you don't want too high a range. You want an optimal range. You don't want to be hypoglycemic and you don't want to be hyperglycemic. Likewise, cholesterol ranges between currently are 125 to 200 milligrams per deciliter. Our optimal range is 160 to 180. Too low a cholesterol range is unhealthy. Too high could be considered to be dangerous. You want to be somewhere in the optimum level. So identifying hidden health trends. Well, we've seen that linear reports, be they 27 biomarkers or 60 or more, are hard to join up all the dots. I mean, just imagine trying to sit down for 2 hours and join up all the dots. You're not being paid for that 2 hours, so you would much prefer, in my opinion, and I certainly do, to join up the dots very easily and see what trends are occurring. So I want to go back and have a look at the previous patient's results again, and this time put it in context with the FDX reports. So Miss CH, we know that there were 2 elements here which were out of range, which was the MCH in the first column down at 33.1 picograms, and serum magnesium at 1.03 nanomoles per litre. 2 items out of dysfunction. However, when we start looking at the blood test reports as reported in the program, we can see that Miss CH, which had 2 abnormal markers in the NHS report, has 10 abnormal markers in our functional DX report as we move away from the optimal range. So we've got 8 deviations from optimal there. And you'll note the additions of ratios, sort of BANT to creatinine, sodium to potassium, calcium to albumin. And there's loads more ratios that appear in the program. All of these start telling fantastic stories. You never see these on doctors' reports ever. Maybe once in a while I might have seen a ratio, but it's very rare. And usually they're in the more upbeat clinic laboratories. The way the report works, anything in red is above optimal range and anything in yellow is below. So you've got an easy to see range. If you have one arrow, you're above optimal. If you have two, you're above standard or clinical. And if you see a warning triangle either up or down, start to take it very seriously, and you may want to be starting to consider whether your patient or client should be thought about as being referred back into the medical system, because they may have gone too far down that slippery slope. You'll also see that the last two tests are reported on here, and you can see a red thumbs down as the progress is down and a green thumbs up if the progress is an improvement. And then one of the most beautiful things about the program from my perspective is how are my patients, my clients doing over a period of time. The last 7 blood tests are reported. The latest on the right and the earliest one of the 7 are on the left. And as you can see, if we go down to creatinine, where there's been a report for all 7, in this case, the client has never managed to get back into that blue little bar in the second column, which is that optimum range. They've been constantly down, and so one needs to look at that. And again, we can see how alkaline phosphatase has been fluctuating. It dropped down quite dramatically and it slowly climbed back up again. And then we just go through to TSH. Now, it's very interesting to see her TSH levels here, even though at 0.87, this is going back a couple of years, and an almost non-existent 0.03, because her free T4 levels were considered normal. No one considered subclinical hypothyroidism. Yet I did mention to you earlier about the elevated serum magnesium, which was a potential sign. But these are the 2 tests which are the gold standard in clinical testing for thyroid dysfunction. It's a travesty of justice, in my opinion, and anyone who is involved in thyroid dysfunction can tell you need a lot more markers than that. Likewise, there's been constantly elevated MCV and MCH. This is indicative of B12, folate, and with depressed MCH, that's B6. And the monocytes, eosinophils, and basophils can be utilized to establish whether there is any dysbiosis occurring, whether there are any intestinal parasites. And 3 along, you can see that, sure enough, they were all elevated, 8, 5, and 1, all above those levels. And that would be a clear sign of a marker to assess gut dysfunction and have a stool test, in my opinion. We also get a percentage deviation from optimum. So on this long list of items here, you get the green bars on the far right column show you what's optimal, and anything that's red is high and anything that's yellow is low, and it's then ordered into which of the percentages are furthest away from the mean. So cholesterol's the worst in this case, followed by MCV, whereas creatinine down at the lowest is the worst, and then alkaline phosphatase. So we go back to Mr. G. Now here's 3 pages of 60 biomarkers is pretty enormous. Now you can interpret the results now with a minimum effort because it's all comprehensively and explained and laid out for you. Here are his 3 pages. I said there was about 10 markers in there, and here is his blood test report. 32 abnormal markers versus 10 on the 60 markers measured by the lab. Now they're starting to make sense of the number of dysfunctional elements he's bringing into clinic. Incredibly helpful and useful. You can see alkaline phosphatase, 28. I mean, an optimal level is between 70 and 100. 28 is almost non-existent. That to me is very worrying, and somebody who's in need of establishing that zinc status needs to be repaired. It also makes me think from a nutrigenomic perspective whether he's got an alkaline phosphatase gene SNP that needs to be assessed or not as well. You get an out of optimal range report. So for every little arrow up and every little arrow down, you get a box or a description. For example, ferritin, three boxes down on the left on above normal, at 218 micrograms per litre. I quote, is the main storage form of iron in the body. Decreased levels are strongly associated with iron deficiency, where it is the most sensitive test to detect iron deficiency. Increased levels are associated with iron overload, an increasing risk of cardiovascular disease, inflammation and oxidative stress. I think this is a fabulous marker along with CRP and a high sensitive CRP for assessing oxidative stress. And this is a man who's got a lot of stress, has an incredibly stressful job, hugely high powered stressful job, travels all the time, and is, in my opinion, at great risk from developing cardiac dysfunction and metabolic syndrome as well. And likewise, below optimum, alkaline phosphatase I've discussed. In this case, they did his testosterone levels, and his testosterone levels are low, not untypical for somebody who's stressed. And when you've got a stress situation like that, you may well have a pregnenolone steal or a cortisol escape, and now you're losing the pathway, steroid hormone pathway, all the way down to the sex hormones. What's important to look at here is the fact his lymphocytes are so depressed. His lymphocytes are depressed at 16.1%. This could suggest a chronic viral infection. In fact, his white cell count was really quite high, and so I would suggest there is something viral going on as well, which is helping to create the dysfunction. And when the immune system becomes depressed like this, all sorts of opportunistic pathogens start to wreak havoc on the body. We get a functional index report. So, okay, you've got all the individual markers. How does this reflect to the individual indexes like GI function, thyroid function? Well, his GI function is running at 65%. So there's something to look at going on there, but you can see his immune function is at there's 100%, almost 100% certainty about that. His lipid panel, needs looking at as well, and he has oxidative stress. And with each and every one of these, you're going to get a little box, as you can see to the right, saying immune function index. It's going to say why it's being looked at, what percentage it is. In this case, it says dysfunction highly likely, much improvement required, which is, I think, quite amusing. The rationale is that the white cells are elevated, globulin was low, neutrophils are elevated, lymphocytes are down, and alkaline phosphatase is down. So you've got all these different elements from all over the blood test, but here you've got a program that's bringing it all together. And the elements that are considered to create this algorithm are total white blood cells, globulin, neutrophils, lymphocytes, monocytes, albumin, and alkaline phosphatase. And likewise, you get the same with the oxidative stress and everything else. Every other marker that's on there is going to have a box written about it in exactly the same way. You get a nutrient index report. So is his hydration good? No, it's not. Why? Because his urea nitrogen is elevated, his sodium's elevated, his potassium's elevated, he's stressed, his red blood cells are elevated, his hemoglobin is elevated, and you consider obviously albumin, urea, sodium, potassium, protein, etc., all the way across. You see there's carbohydrate index is low. There's a lot of improvement required. This is where you start looking at the diet. Is your diet too high in refined carbohydrates, etc.? Because they will show in the blood, and it will show in the blood early. So the one thing about the blood I have to say is that we are homeostatic organisms, and the blood is what is the transport system of the body. What goes around from the tip of your toe has got to be pretty much the same to the very top of your head. It's got to have the same homeostatic relationship. Its alkalinity's got to be preserved, the body temperature's got to be preserved, the nutrients have got to be the same. And if there is dysfunction in this homeostatic transport mechanism, you can rest assured that all is not quite well in the state of Denmark, to paraphrase Hamlet. There is something that needs to be looked at, and when you take it in conjunction with the clinical picture that you're looking at, work is required. So we now take this, what's going on, and we say, well, okay, we've seen the functional indexes out there, but what could they possibly refer to? So this report is only for advanced practitioners. In other words, it would be for you as practitioners, that you would have this in front of you. I can assure you your patients would not. It doesn't appear in their report, to give you an indication of what to start looking for. In this case, has this person got Helicobacter pylori? Have they got bacterial infection? Is there renal insufficiency? And as you can see, I've cut out a couple of these blocks here. The Helicobacter pylori, what do we consider? Bacterial infection, the rationale and the elements considered on there. Helicobacter pylori is of course a bacterium anywhere, but this might give you a thought to say, well, let me assess their hydrochloric acid function. And hydrochloric acid function is critical, and I see this enormously. I mean, huge amount of times I see low hydrochloric acid function, low zinc function as well, and it's endemic. I mean, it shocks me that we have this problem that occurs, and with low hydrochloric acid function comes the risk of pathogenic invasion into the GI tract. Comes the inability to absorb B12 appropriately. You can't ionize calcium ions, so your calcium absorption goes down. Your iron, your main elemental iron can't be ionized appropriately, and so you have these problems occurring, and you can start to pick this up very early. In this case, I would want to see that his hydrochloric acid function was okay, and I use bicarbonate soda challenge test just to get an assessment. Can you burp after you've had this? And if you didn't burp, then let me double the dose and see if I can generate a burp the next day. By the way, it tastes disgusting, and I do apologize to clients in advance, but sometimes they can't even raise more than one little burp. And I go, well, I'm not surprised. And so we get to work on that, and as changing the acid function in the stomach can make a huge difference. You also get a what to look for when values are out of range report. So in this case, what do you look for? If glucose is elevated, what does it mean? Consider insulin resistance. Consider early stages of hyperglycemia or diabetes. Consider metabolic syndrome or insulin resistance. Thiamine, vitamin B1 need. Is there a resistance in the anterior pituitary gland to cortisol? Is there acute stress going on? Is fatty liver a problem? Now, you have in front of you a client, you know their clinical symptoms, they've come in complaining to you, you've assessed them for all the physical signs and symptoms, they filled in a questionnaire, you know what their diet and lifestyle is, and now you can start taking all of this all these elements here, and you can start putting together a really good clinical picture of what you want to do and where you want to go further and how you want to start specializing with their diet. Likewise, in this case, what to look for if you've got elevated hemoglobin A1C or glycosylated hemoglobin. And when you've got 0.07, that's 7%, that's very high. And now you're getting concerned about diabetes mellitus and certainly insulin resistance. And so you put all these factors together and you start looking at the elevated cholesterol levels, and you go, you could say this is a person who's on the rocky road towards metabolic syndrome. Right, sir, this is the trend you're exhibiting. However, let's try and arrest that possibility. In other words, before you slide down the slope, let's head it off at the pass. Because once you go past the pass, you're sliding down. Stopping that slide is going to be difficult. And when you get onto pharmaceuticals, it gets even more difficult because then you have side effects and side effects of side effects, and then you have cocktails, and that's not where we want to go as therapists. We will also recommend further testing and make suggestions about further testing. In this case, two of the things we're suggesting. This was for another patient, by the way, SCAL, is a report I'm going to show you towards the end. Have a look for Helicobacter pylori and test out and ensure the zinc deficiency. When I come to produce the reports, these are the reports that you get. What I haven't showed you here, you will see this on the later report, as a product summary. That's not quite going to come into the UK just yet. That depends on the companies whether they want us to do it or not. But you'll get everything on this list. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and like 12 reports, of which the patient will get anything up to 9. So that's a lot of data on there, lot to consider, and quality, efficient, brilliant data to consider. And of course, the front page of the report is your name, who you're testing, when it was tested. My name is on there. My clinic is on there, Centre for Applied Nutrition. My telephone number is on there. My email is on there. So now we've seen the reports, the blood panels. So I put together a number of blood panels. I didn't want to have a mix and match thing. I just wanted to put together basic blood panels that could be called upon, that were simple, straightforward, and comprehensive. I have a basic, this is FDX01, an intermediate FDX02, a comprehensive number 3. The thyroid basic is known as number 14. There will be a thyroid complete coming, which will have everything you need for the thyroid, including the reverse T3 and T3 uptake, etc. You've got 59 markers with FDX01, 67 with 2, 78 with 3, 56 markers already on the basic thyroid, more to come on the complete thyroid, and you can add on if you really want. The one I designed primarily for most nutritional therapists is number 2, and it comes with virtually everything on there. What is not on there are the thyroid antibodies. You can add those on because not everybody wants to have thyroid antibodies tested, and if you do test them, you'll test them once and you may not test them again on the follow-up. So you can choose to add those on each time. Pricing, FDX01 including the report is £149, 249 for the intermediate, £299 for the comprehensive, which is basically has all the hormones in it. Not all of those are in FDX02 because I didn't consider that nutritional therapists necessarily want to test hormones all the time, and the thyroid basic at £150. To draw the blood and spin it, and any add-on tests, they are priced separately. So I wanted to show you Mrs. W. This is an interesting case. This was a woman who came and I did an interpretation for her on a genetic test. This was her deiodinase 2 gene, which assesses whether there's a conversion of T4 to T3, and it came out as heterozygous. But she felt awful, and she was diagnosed as hypothyroid and on thyroxine, synthetic thyroid hormone. And she was still not feeling right. She was tired, she was ill, and she decided to take charge of her own health. And most people who are subclinically hypothyroid eventually give up and decide to take charge of their own health. She's 70 years old and she just feels like yuck all the time. So I said to her, well, the good news is you're not homozygous, so that we can do something about it. However, I can't tell you whether the gene is functioning properly or not because I need to assess your phenotype, which in other words, I've got to go from the cards you're dealt with, the genotype, to how you're being properly expressed. And she was going off to America because she has a place to live over there. And so she went and had a full panel done in America. And the panel showed that she had a thyroid conversion issue, so the DIO2 was not converting properly. She needed thyroid support. She needed selenium. Her report showed her TSH as low, which is not surprising. She's on thyroxine. Her T3 levels are low. Her T3 uptake levels are low. Her reverse T3 is just elevated. So this is just not working for her. And what had never been tested for her in all this time were her antibodies. autoimmune condition, and she was showing an autoimmune thyroid condition. Now, you will know, or you may know that somebody like Tom O'Brien will talk about gluten, and he will talk about its effect on autoimmunity. And the first port of call, the first thing that gets hit with gluten sensitivity, not just celiac, which is autoimmune, but non-specific gluten sensitivity, is the thyroid. And usually it can result in an autoimmune thyroid condition. And so she went from loving her bread and dairy to not having any bread or dairy or any gluten or any dairy at all overnight, instantaneously. No questions asked. I can be a cruel taskmaster. And again, we go through what was above optimal, what was below optimal, why, what's in there, what we're testing for, looking at the functional test. And this was only for the thyroid. Nothing else was tested. And this also showed that probably there was a need for iodine as well. Obviously, the health concerns here was hypothyroidism for T4 underconversion, which is what we were looking for, and secondary hypothyroidism. So this is prior to the thyroid packing up completely, and that's the one thing we don't want, frankly, because if it ain't totally gone, maybe there's a hope to save it. What to look for when values are out of range. Lots of description. So this is a highly educational program as well. And then as a result, we agreed T4 to T3 was a conversion issue. She had an autoimmune thyroid function. She had a need for selenium. A possible suggestion to consider T3 as a hormone in its own right. Now, this is not something I can do in my remit as a nutritional therapist. So I suggested to her that she should speak to the USA doctors that she had out there, because working with hormones in America, bioidentical hormones, is quite the norm. And so they prescribed for her natural thyroid hormone, which comes in a ratio of 4:1 of T4 to T3. It's natural, so it has either a bovine or a porcine source. She was autoimmune, so the dietary suggestions included strict gluten and dairy-free diet, and we added minerals and thyroid support as well. 2 weeks later, it's one of those great things where I get a telephone call and she says, "I just wanted you to know I ran up the stairs for the first time in years, and I'm not out of breath, and I'm now going off to play tennis," which little things like that kind of make me feel warm and fuzzy every now and then. So it's great. And what did I do? We ran some tests. We did a report. The report indicated what was needed to do, some simple dietary changes, and big change to her health, and she continues to make progress all the time. So let me summarize. We're identifying hidden health trends. You could become an immediate blood chemistry expert. In fact, you will become one, because the report is doing it all for you, and you'll be continually learning and all the time. There's a full national coverage. We've got more than 80 biomarkers at your disposal. You've got sophisticated, clear and comprehensive reports. Prices are extremely affordable. They include reports, and we have an own test interpretation service. It improves your image with your patients, because you're providing them with this fantastic report. You've got your name on it. It saves you a huge amount of time interpreting results. It's better allocation of time, less extraneous hours, means that you can increase practice work and frankly get a better return for the amount of hours you put in. As a nutritional therapist, all I know is I spend an awful lot of hours and I never earn a penny for those. Improves your practice accuracy. You become a better practice for it, and you've got the opportunity to create new income streams. In other words, you can offer this to a wide range of people, saying, would you like your health status checked? Would you like to know where you're trending towards? So it opens up new avenues for patient generation, improves your practice because it's a great service, and creates added value to both your practice and business. And frankly, you achieve success, as I showed you with Mrs. W, faster. Before I close, and I'm going to show you a report at the end of this, and then we'll open for questions if there are any, I want to just make an announcement about phlebotomy training. One of the biggest problems about getting testing done is finding enough people out there and sources where you can get blood drawn and blood spun. And it's driven us mad over the years. So we decided to put our heads together, and we've come up with a new career and practice revenue opportunity. So we want to evolve a nationwide phlebotomy blood draw service. So we've instigated a training program, which is going to be limited to classes of 15. It'll be a training in theory, and you'll get 2 days NHS real-time on-site practice and training, which if you achieve the standard that the trainers will set, because they're NHS standards and they're NHS people who run the NHS system, then successful participants will receive an NHS recognised certificate. All equipment's going to be provided, including centrifuges, consumables. There'll be National Register entries. There'll be lots more things we're working on to be announced. Where you're on the training days, the hotel accommodation will be included if needed. We're not planning on doing more than 6 courses a year at present. It may even only be 4. And anyone can apply for this. This is for phlebotomy. This is for drawing blood. And being a qualified nutritional therapist or qualified anything is not required status, just a qualified, intelligent, caring and careful human being. So this is very exciting. It's good news, and it's what the profession needs. And with a nationwide area, those who don't want to do it will have access to colleagues that can, and you'll be able to enhance and increase your business and revenue opportunities as well. So thank you for this. And before I end for questions, Mary, if we can just go over, I'm just going to run through a very long report, show you the ESCAL report, show you what it looks like in full, but I'm not going to really talk you much through it, and then we'll open for questions. Thank you. Okay, so this is patient-client. I've called the practice perfect practice. This is the report as it comes, and so you get a table of contents where these are related to in their index, and disclaimer page, notes where notes would be appropriate, a health improvement plan, and then this is the bit I didn't show you before, but this is where you've got health issues, metabolic syndrome. Here are some products that if you were using biotics research, then you could be using glucobalance, you could be using cytosine pan, you could be using bioglyzyme forte. For hyperlipidemia, you might use their lipid cert, bioprotect tricol, and it goes on through the list of items here. Where an item's already been reported, you'll get this coming up. If it comes up again, it says this product has already been recommended earlier in this report. Please do not increase the dosage because the product has been listed more than once. So we're trying to make it safe. What you would do for B vitamins, vitamin D, and then a summary, so a product summary report of what's involved. And of course this will go to your patients as well. So if you happen to be a biotics research person in the States and this is your choice, then that's exactly what you would be looking for. The blood test reports we've been through. So elevated, one red is elevated, 1 arrow is above optimal, 2 arrows is above clinical, warning triangle means have a very good look at this and find out what's going on. Yellow is below optimal, 1 arrow, 2 arrows yellow means clinically below, and any warning triangles, watch out. In this case you can see there's a warning triangle already going out for LDL cholesterol, and at that sort of level that's of concern. In fact, because the triglycerides are low, it's already starting to hint to me from other patterns I've seen that maybe I want to be looking out for an autoimmune function or dysfunction. And then percentage deviation from the optimum. So we went from BUN creatinine, which are 485 percentage deviation points from the medium, down to MCHC, mean corpuscular hemoglobin concentration, which is only 53%, down to, this is a long report, down to white blood cells, which are the largest deviation. And again, the out of optimum range report, what's out of range, why it is, what are we looking for, etc. You can already see that when I mentioned the low triglycerides, we can already see that thyroid peroxidase antibodies are elevated. So there is an autoimmune condition going on. So these are being backed up time and time again. And again, we've got metabolic acidosis occurring, glucose levels are elevated, there is hemoglobin glycosylated elevated, below optimum. And so this is so far 25 pages through. There's another 37, which I probably won't go all the way through. But again, the functional index, what's in the functional index? What are we looking for? What one should we consider? Tell me all about them so you get an understanding, so you can be coherent when you're discussing it. The nutrient index, what's going out? What are the vitamins we're going to be looking for? So go down to the mineral index, and we have a look at the nutrient deficiencies coming out. So there's a need for zinc, magnesium, vitamin D, thiamine, DHEA. It's not as a hormone we can't deal with in this country, but a need for B12, folate, iodine. So this is somebody who needs a lot of intervention. Got to them just in time, I hope. And again, why and all the elements considered. Clinical dysfunction. So what's going on? Well, we think there's metabolic syndrome occurring. What does this person weigh? What is their waist to hip ratio? What is their BMI? Is there dysglycemia? What are all the issues? And again, explaining each and every one of these. And then, of course, the blood test history report. This was a one-off report, so I've got no comparatives to run against. So you just get this one long line. But if you came back and said, well, I want to rerun this test, then the next time you'd have 2 to compare, and then 3 and 4, and so on and so forth. And then we say for you, what do we recommend further testing? Test for blood lipids, zinc deficiency. What happens if reference ranges are out of value? Then, as I say, about glucose and thiamine and anterior pituitary dysfunction, etc. And this just continues on hyperchlorhydria, which I started to speak about. Whether there's metabolic acidosis. So I'm just going to click through these, and because there's a lot going on with this one particular person. And finally, a disclaimer, which we always put on all the reports, which basically says, this is for the exclusive use of the above named recipient, contains confidential privilege. Simply never disregard professional medical advice. Don't delay seeking medical advice or treatment, or don't stop current medical treatment because of something you've read in this report. This is a health trend report, and frankly, if you've got people or clients who are on under healthcare professionals, remember they are healthcare professionals. Don't rush into their area. They don't like it. I'll end here on this, and I'll say thank you very much for your time. I hope I haven't been too overly boring on this. I'm passionate about this, and I'm happy to take any questions if anyone's got any to ask me.
Thank you very much, Jonathan. I have one question here about the difference between blood serum and for example, if you take a folic acid test and functional medicine practitioners would want to take the cell value versus like a normal serum value. What's your view on that?
You mean red cell testing again as versus blood cell ordinary serum testing?
Yes.
Okay, so if you have having an elevated magnesium level in serum does not necessarily mean that you've got an excess of magnesium in the red cells. You might have a deficiency of magnesium at a cellular level. There's, you've got an intracellular level and you have an extracellular level. And so by doing red cell testing, you're looking at the intracellular levels, i.e. inside. So looking at B12 or folate inside gives you an idea of how much is in there. The question is whether it's getting into there, and if you've got excesses in the plasma, and you know that you've taken the person off of the vitamins or minerals that you're assessing for, and you're seeing an excess, then you know that there's not proper absorption going on. This may indicate that you're looking at genetic polymorphisms and needs to be properly assessed through other factors. As I said earlier, I'm a great believer in homeostasis. The beauty of the human body is it's designed to be homeostatic. You should have a body temperature of around about 37 degrees centigrade, give or take a marginal 0.1 or so, 0.2 degrees, and that allows for a general range. If your blood temperature, let's do it in the old ways, at 98.6, 98.7 was the sort of clinical range of normal blood temperature, 98.6, 98.7. And if you had a temperature of 99, you feel awful. Well, I defy anybody to try and establish what a 0.3 degree rise in Fahrenheit feels like around them in the room. They just won't notice it, but your body starts to produce this. So maintaining homeostasis is everything. And if you find anything that's normal, clinical in the body and in the blood, and you start to see factors that are outside of that, then you need to assess it as there is a disturbance in the force almost. Find out what it is, because the body will do everything to maintain homeostasis. Remember, I said the tip of the toes to the top of the head, everything should be exactly the same. And often the body will deprive other areas to maintain homeostasis so that everything in the body gets an equal share. Does that help with that answer?
That's good, thank you. I have a few more questions here. Question from one asking, what is BAN or BUN and the creatinine ratio? What does it stand for?
Well, BUN is blood urea nitrogen, and creatinine is creatinine. There is a ratio. There is a ratio that exists there. If that ratio is low, it can suggest that there's a liver dysfunction, or there might be an immune activation. In which case, you want to look at the other markers. You remember, as I went through this, I said there are elements that are considered in assessing the algorithms in each and every area.
Yeah. Thank you. And then a question about the blood drawing training. Where can we find out more about it? Contacting you?
Yeah. If anybody's interested or wants to be on this, then by all means get in touch with me, or get in touch with you, or the student group, and just register your interest. This is the first place, the first official announcement of this. Before it's gone out even to the sort of qualified practitioners out there. As I said, this is not exclusively for qualified people. This is for people who want to have a second string to their bow. And it's, look, people pay to have their bloods drawn, and it's very simple. There's no cost for equipment, no cost for anything. There will be a cost for the training, which I will announce at some point. It won't be hugely expensive, and all the equipment's provided, and people will be directed. So every time we as a company get somebody who comes into us and says, well, we want the bloods drawn, we can put them to the people we've helped train. Yeah. If other laboratories out there want to utilize the national service, let them use it. We're not making it exclusively for us. This is going to be open, widely available to everyone. I think it's a fantastic opportunity for people to consider. It may not be for everyone. Not everybody wants to draw blood. That's that's for sure.
Yeah. Thank you. I have time for one more question. And a question here asking about how the GPs are recognizing these tests. Are they applauding or are they skeptical?
GPs are always skeptical of anything that is not GP. First of all, this is not a diagnostic test. No test is diagnostic. If you look at the all the functional tests out there that come in from America, they always say this has not been approved by the FDA for diagnostic purposes, for testing and evaluation. They all have that on there. None of them are diagnostic. That is not to say GPs don't look at this and understand the meaning of the word health trends, and they do. And the reports are that a lot of GPs are looking at this and going, yeah, because it's reporting a trend, and they can see a trend away from the norm. And it's easy for them to see. And look, let's be honest here, all the hard work has been done for them. And I promise you, if you get you put 60 blood markers in front of any GP and ask him to go through that test and assess it in, shall we say, the 10 minutes he might have with an ordinary NHS patient, I defy it won't happen. It can't happen. You know, they're not that good, and I'm certainly not that good. And I've been doing this and working hard at this for years. But if you run it through the algorithms, and remember I spoke about Wine or Fine's report on algorithms. This is algorithmic. This is taking blood and making an algorithm, making it easy to understand, and it divides it up into the areas. Is the immune function functioning? What markers do we look at? How dysfunctional is it? We have a functional index report, and it goes between 0 and 100%. Is it chronic? Is it acute? Is it bacterial? Is it viral? Is it just developing? If you look at the white cells for monocytes, eosinophils, and basophils, and you find them elevated, sure as eggs is eggs, you're going to suspect parasitic disturbance in the GI tract, and that may well fit in very nicely with somebody coming along and complaining of all those problems that we face as nutritional therapists, of bloating and just feeling rotten in the tummy and so on and so forth. And then you can say, right, that's there. Now you've got a choice, Mr. Client or Miss Client or Ms. Client. We can, if you like, assess that properly by doing a stool analysis, cost you X, or we can treat it accordingly, rule out yeast or whatever, but we can start to treat it by boosting the immune system and putting in appropriate improving materials that will deal with that area of dysfunction. So people have got a choice. When people can't afford to do these tests, and lots of people can't, then you've got a choice. You can go in and start working with them with a reasonable degree of confidence that there is something dysfunctional going on there that you're trying to put to rights. But you're not diagnosing it, you're just seeing it as a trend. And it's a strong trend away from the norm.
Excellent. Thank you very much, Jonathan. It's been very valuable. I'm looking forward to be fully qualified so I can utilize the system for sure.
What I would say, let me just say here that if anybody wants to use the test or see it, they can't actually access it themselves. It's inappropriate. But I'm happy to allow them to run it through me as their own test, and they can then it will be exactly as the FDX costs, and I will be quite happy to spend 15-20 minutes going through their results, for those people who are here or students of BANT or their families or whatever, because I believe and passionately it's essential that every nutritional therapist use this, because this is the best functional test that there is.
I'm sure we will all take you up on that. I will get our team members to send out a copy of the presentation and with your email address, so people can follow up with you directly. If someone wants to continue the conversation further, it's a link here to our LinkedIn page. And next month's meeting is going to be about nutritional resources and regional meetings hosted by BANT. And we will send out emails about that shortly. Thank you very much, Jonathan. Do you have any final comments?
Me? No, I just hope everyone enjoyed it.
I'm sure we all did. Thank you very much.
A pleasure.